So good evening, students. A warm evening to one and all. My name is Dr. A.S. Nath. I'm your nephrology faculty at Conceptual Medicine. This is our second season, and this time we're doing it on the latest edition, based on the latest edition of the Harrison's textbook of internal medicine. And me being a nephrologist, I'm also heavily relying on the latest guidelines and updates so that we can bring you the best content which will help you in preparing for your NEET SS and NE SS examinations. So to start off nephrology, uh, I am going to start with a very simple topic, which is urine analysis. And it's a very, very important topic to be understood on a day-to-day practical basis. Okay. So without further ado, let us go into the talk per se. So this is a slide that I always start off with when I'm taking my first class in conceptual medicine. So this is a beautiful, I like this Venn diagram too much. And here you can see, and this message has to be very, very clear in your mind. Preparing for an MCQ exam is only that much. Okay, preparing for an MCQ exam is only that much. Whereas the knowledge of medicine is a superset of that. And your actual practice of medicine in the clinic, in the hospital, is much more than that. Okay. Getting a good certificate from the patient is all the more important. That's what we all strive for. So this is the first step. That small circle is the first step to reach the second and the third circles. So wishing you all the best in your journey for the quest of knowledge. And as I told you, these are my references. One is the Harrison's textbook of medicine, the 22nd edition, the latest one, in fact, and also the latest edition of Fee Halley, which is the comprehensive clinical nephrology textbook. So the opening remarks to this class would be, we often tell in our clinics that doing a urine sediment microscopy is actually like doing a liquid gold biopsy. Okay, so we call urine liquid gold. So that's how important the study of urine is to kidney diseases. And number two, it is an invaluable initial investigation into the diagnosis of kidney disease. And all of us have to be well versed with doing microscopy ourselves when we get a urine sample, or at least for the interpretation of a urine microscopy report. So the first question that has to come up in all our minds is, which is the urine sample that is most preferable for our examination? Okay. So we have so many ones. So let's go on and discuss what are the different types of samples that are available. One is the 24-hour urine sample. Okay. Where you collect the entire volume of urine voided in a day. You start with the second voided urine of the day, of day one, and collect all the urine through the day and the night. And the last sample will be the first voided urine of the subsequent day. So in short, the second urine of day one to the first urine of day two would be your 24-hour urine sample collection. It is tedious, obviously, goes without saying, and it also needs an extra test for verifying the accuracy or the adequacy. Okay, so it's very important for you to verify the adequacy of the 24-hour. Suppose somebody brings 1.5 liters of urine and says, "That's all I passed today." How can you believe whether he actually passed that much or not? So we'll discuss that point in the next slide. So please remember that 24-hour urine sample is very good. It's the gold standard when you are doing a protein estimation or even the estimation of certain other substances, but it's very tedious. Sometimes your patients are not happy when you're ordering that test. And also it's very important that you verify the adequacy of the 24-hour urine. Okay. Because why? You have to remember that not the entire volume is put into a machine and the result comes. You have to understand that. So the small volume of sample is tested, and then you multiply the result with the volume of urine actually given to you. So if somebody passes 2.5 liters and then gives you only 1.5 liters, the report is going to be completely wrong. Okay, do you understand? Okay, you understood my point, right? You're not putting the entire volume of urine into a machine and testing it. You're taking only a representative sample, and then in the end, you multiply it with the volume of urine. That's how it works. So it is very important that the patient adheres to your instructions and gives the correct amount, the entire volume of urine. Number two is your midstream clean catch in the early morning void. which is your commonly called the spot sample. Sometimes it's practically difficult to get the first voided urine. So even the second voided urine is fine, but it has to be a clean midstream catch. Number three, yeah. So the midstream second void urine, so either the first urine or the second urine. And number four, you have a sample that is got from either a Nelaton catheter or a suprapubic catheter. Okay, a sterile sample can be got that way. Number five, you get samples from the indwelling catheter. Somebody has a Foley's and then you collect it from that catheter. So that is the least preferable. So going into the other points about these tests, when you talk about a spot urine sample, it is the test that is given by the KDIGO, which is the Kidney Disease Improving Global Outcome Body, the global body that gives us the guidelines for managing kidney diseases. So they tell that it's the most practical and most valid sample that you can get, either the first or the second void urine of the morning. And it's okay for albuminuria testing, but you're really doubtful whether it is okay for microscopy. When you talk about the first voided urine, the disadvantage that you have is that it has stayed in your bladder for a considerable amount of time, right? So around 10, 12 hours overnight, it has stayed. So because of the stain and because of the concentration, there is a possibility that it can lead to lysis of certain particles and therefore it can affect your microscopy. When it comes to studying the urine sediment for microscopy, the second voided urine may actually be more useful. Okay. And when you talk about SPC and NELCAT, you're talking essentially about pediatric patients. Okay. When children are there, it is difficult to get, ask them to void and get. We're talking about very small children, right? Toddlers and infants or newborns. It's sometimes difficult to get a sample from them. You don't know when they are going to void. So either you can have a bag sample, okay, or a NELCAT sample or a suprapubic catheter sample. But the problem is it is invasive and it can cause hematuria and you can find RBCs in the urine. And last is your indwelling catheters, which is obviously a bad choice, goes without saying. I don't even have to explain it. There is a lot of contamination that is possible. So you can have hematuria, leukocyturia, bacteriuria, candiduria. Okay, you can have fungi in your urine, and you really don't know whether it is because it is an improper sample or it is a true disease. So I told you about it. If you go back to the previous slide, I told you that it's very important for you to let me try and get a laser pointer. Yeah. So I told you that it is very important to verify the adequacy of a 24-hour sample. And that's where this point comes. And this is a screenshot from your Harrison textbook that whenever you're ordering a 24-hour urinary protein, it is very, very important that you also order a 24-hour urinary creatinine. Okay. Both should go hand in hand because it is useful for you to verify if the patient has submitted the entire quantity of urine. Okay. Because let us read the line from Harrison. For a 20-year-old to a 50-year-old man, creatinine excretion should be around 18.5 to 25 milligram per kg body weight. And for women of the same age, it should be around 16.5 to 22.4 milligram per kg body weight. So roughly we remember it as, 25 to 30, 25 for males and then 20 for females. For example, an 80 kg man is there, so he should excrete somewhere between 1500 to 2000 microgram of creatinine in an adequate collection. Okay, so that is the point that I wanted to bring to you. So suppose you have a patient with nephrotic syndrome, okay, nephrotic syndrome where you have a lot of protein loss in the urine more than 3.5 gram, that is 3500 milligram per day to be precise. In such a case, if you want to really quantify how much urine he is passing and the creatinine is normal, it's very useful for you to do 24-hour urinary protein plus 24-hour urinary creatinine so that you can verify the adequacy of the urine collection. Okay, I hope you got that point loud and clear.